Okay, the next case is case number 41. And this, you can see, was taken by a nucleation technique. So once again, we think benign when we see that. And the story here is an 80-year-old man comes in with an enlarging lesion on the scalp. It says male on her scalp. That's an interesting typographical error. But anyway, the best diagnosis here, and you can see it's a neoplastic process. And go to higher magnification. It's got all of these bulbous aggregations of keratinocytes with this pink hyaline material. And this is what we call tricholimal cornification. So this is the type of cornification you see with a pilar cyst, if you will. The problem here is that you've got massive areas of this bulbous pseudoepitheliomatous hyperplasia associated with this. And once again, when you're dealing with a large lesion, look at the individual smaller aggregations and see if they show anything that's atypical. And here they do not. They show squamous eddies, which is a sign of benign. And you can see the cells are really typical. There are no mitotic figures. So there's some calcification. And you've got this pink hyaline material, which is really, it's actually keratin. And this is analogous to the cornified material that actually gets produced at the level of the isthmus of the follicle, or in a catagen hair follicle that's shifted from telogen into catagen. So this is a proliferating pilar tumor, proliferating tricholimal cyst, if you will, is another name for that. Another name is WEN. You see the dystrophic calcification here. And the main thing here is not to misdiagnose this as squamous cell carcinoma. Okay, so that's actually a fairly common mistake that's made by a lot of dermatopathologists. Even. This is not a cancer; it's totally benign, and you don't want to overcall this. So it's not a squamous cell. It doesn't have marked atypicality of the nuclei, doesn't have any mitotic figures. Squamous cell carcinoma doesn't really undergo this classic sort of tricholimal differentiation as you see here. So this is not a squamous cell. Pseudoepitheliomatous hyperplasia, well, maybe it kind of is that a little bit, but that's not really the classic diagnosis here. This looks like a cyst. So this is a cyst, and it's got this proliferating pilar epithelium. It's not proliferating squamous epithelium like you see with the epidermis. It's a different type of epithelium. It's more of the follicular epithelium. And it's obviously not a cancer, as we said before, and it's not a tricholimoma. So this is a proliferating tricholimal cyst, but it's not a tricholimoma. So just make sure you know that entity. For those of you who've paid attention in your residency program, I'm sure you've seen plenty of those, and you should be able to get that diagnosis pretty straightforward. Okay, the next case, number 42, is an excisional biopsy. And you can see it's a neoplastic process at low magnification. It's pretty big. It's probably maybe a couple centimeters in size across here or so. So it's a fairly large excision, and it shows this neoplasm comprised of these cells that have this. It's this pinkish, almost. It's not really red, but it's kind of pushing towards red appearance to it, and it's a spindle cell neoplasm. So once again, we talked earlier about non-epithelial lesions, spindle cell lesions. The main three that we think about are fibroblasts, histiocytes, and muscle, smooth muscle. You can see other lesions can give you spindle cell morphology. You can see that with some melanocytic lesions, with endothelial lesions, even with squamous lesions sometimes. So here we're dealing with these large fascicles of cells that have these blunt cigar-shaped nuclei that have some little vacuoles at the periphery. This is classic for smooth muscle. So here we get a smooth muscle that's kind of cut in cross-section here, and then this one is cut in longitudinal section. So you can see that right there. You can imagine that these are fascicles of cells kind of going this way and this way. And they basically now give you a second-order question here. The lesion was biopsied to spindle cell neoplasm with immunohistochemistry revealing negative for SOX10. So that rules out a melanocytic lesion. CD31 rules out a vascular lesion. Epithelial membrane antigen, well, that'll rule out lesions with epithelial differentiation, some granular type lesions, and adenocarcinoma. Cytokeratin is negative. CD68 was negative, but it was positive for both Desmond and smooth muscle actin. So this is a neoplasm with muscle differentiation. Now we're going to look around and say, well, do you think it's benign or malignant? And it's pretty big, as we talked about before. It's not very well circumscribed. And if you start looking carefully in this lesion, you're going to see there's some mitotic figures and some atypical cells. Now, these lesions, even though they get called leiomyosarcoma a lot of times, they're often really pretty low grade. So when a leiomyosarcoma develops in the skin, and this one really doesn't have a lot of atypicality, I might not have actually signed it out as a fully developed leiomyosarcoma. I might have called it like an atypical leiomyoma. Really not even all that atypical because it really doesn't have a lot of mitotic figures, but it's big. And so that might be why it was ultimately called that. And if you see this on the board examination, they're probably not going to give you the differential between leiomyosarcoma and leiomyoma. They really want you to get into the muscle category. So don't worry as much about that. They're not going to ask you to tell the criteria between benign and malignant. And generally, you need to see a lot more mitoses than I'm seeing in this field. So it's possible there may have been other cuts that show a lot more mitotic figures and more atypicality. I really don't see that many here. I see some pleomorphic cells, but for leiomyosarcoma, I'd really like to see a lot more mitoses and a lot more atypia. But anyway, be that as it may, your choices here were leiomyosarcoma or / leiomyoma, spindle cell melanoma, no. Atypical fibroxanthoma, that was saying positively for CD68, so no to that. Although a better marker now that we're using, in case the board asks this, is CD10. Much better marker. Now, it's not specific for AFX, but in the context of negative staining for squamous cell and for melanoma and other things, it's great. It's the best stain that I've ever used for AFX. So I like that stain. And spindle cell, squamous cell, obviously no, and angiomatoid fibrocystocytoma, we talked about that a little bit earlier. It's clearly not that. That would be a DF, a variant of dermatofibroma. So this is a leiomyoma / leiomyosarcoma in that case. Okay, this is one you probably will not get on the exam, but nevertheless, once again, if you looked at this and you figure this out, congratulations. And always if you can get a tough lesion on your own, when the board asks you something, it's better to kind of over prepare for these kind of examinations than to under prepare. So you should go in feeling like I've done way more than I need to, so I know I'm going to pass, and then maybe you'll ace it. So but you always want to make sure that you over prepare for these exams. You do not want to have to take it again. One shot deal. You want to take research. You don't want to take the exam again. You don't want to get into purgatory. So we got it looks like maybe another incisional biopsy, maybe some kind of a nucleation biopsy. We've got a lot of spaces plus red. We think of vascular possibly in that situation. Something's bloody here. So we're going to go to higher magnification. And indeed, we see all this blood in here, but we start looking at even higher magnification. We say, hey, wait a minute, these are not endothelial cells. This is an epithelial lining here, it looks like. It's got cilia on it. It's got maybe 2 or 3 layers of cells. It doesn't have any apocrine differentiation. It kind of looks like a gland, if you will. It's got this stroma that's kind of myxoid with a lot of inflammation in it. And it's got some fibroplasia here. So this might have actually occurred near the umbilicus, or possibly in a scar of maybe a woman that had a C-section, something along those lines. So this is an example. You look at your choices here. It's a 35-year-old woman. That's the right age. Tender nodule, lower abdomen. The best diagnosis is omphalomesentiric duct polyp. No, it's clearly not that. Omphalomesentiric duct polyp is lined by gastrointestinal epithelium. Doesn't have a lot of red cells in it. So again, they're not going to ask you that either, because that's pretty bizarre. But if they do ask you that, it'll probably be in a multiple choice question with a pediatric dermatology. And that wouldn't have this ciliated epithelium that you see here. It's clearly not a hydrocystoma. You guys know what that looks like. It's not a median Raphe cyst. That's usually seen down in the penile area. And it's also lined by urothelial epithelium. It's not lined by this kind of epithelium. And then cutaneous ciliated cyst. Well, theoretically, well, yeah, there's the skin and there's cilia and it's a cyst kind of looking lesion, but it's really not a cyst. It's really glandular epithelium. And what this is cutaneous endometriosis. You might have gotten that right when you looked at the slide. I hope you did. That's great. But this is probably not something they're going to ask you on the exam, just so you'll know. But you can kind of work through this. They might ask you about, say, median Raphe cyst. They might ask you about cutaneous ciliated cyst. So it's not a bad idea to know some things that could be in the differential diagnosis of that. And we always name cysts by the lining. Okay, so again, this is not a cyst. It's really multiple glandular elements here. But when you look at a cyst, you always look for the lining, and then you make a diagnosis based on what the lining of the cyst is here. But this isn't just a cyst. This is multiple glandular epithelium. This is ectopic endometrial tissue, and it's commonly seen in a setting like this. It's often seen in the lower abdomen of a younger woman, usually in they're still menstruating. And so you can actually see, this is sort of analogous to what goes on in the menstrual cycle. You get the shedding of the endometrium and erythrocytes in there. So this is really what an actual endometrium would look like if you took a biopsy of some of a lady's uterus who was in a menstrual stage here. So that is cutaneous endometriosis. You probably won't be encountering that on the exam, but still, you've learned about it. Okay, and the next one, number 44. Turn this around a little bit here, and we'll bring up this piece over here. And this basically is just a changing lesion on somebody's shoulder. And you see it's got this shave biopsy. It's an epithelial neoplasm. It's got squamous epithelial differentiation. It's got these squamous eddies in here. It's got some horn pseudocysts. That's one side of it over here. Here's another side of it over here. This has got a lot more horn pseudocysts over here. This is probably a better one to look at. So once again, the lesson is if you get a scan slide, look at the whole thing, try to find the most characteristic area. And hopefully if you saw this, you would instantly say, that's a seborrheic keratosis, no problem. The thing that's a little bit more difficult is we look down in the other area over here, you've kind of got some pseudoepithelial hyperplasia. And it looks, this area right here looks a little bit like an inverted follicular keratosis or a verruca with squamous eddies. So sometimes we see irritated seborrheic keratoses that have warty features in there. Sometimes we see some atypia that can simulate a neoplasm, a squamous cell carcinoma. So when you get an irritated seborrheic keratosis, they can take on some other unusual morphologies, as you see here. But this is a pretty straightforward example of an irritated SK. And, this part is a classic seborrheic keratosis. So hopefully you all were able to recognize this one pretty characteristically. This was again, 62-year-old woman. That's the right age. Irritated seborrheic keratosis, the right answer. Poroma, no, this is not a poroid lesion. These are not eccrine cells here. These are not poroid differentiation. These are horn pseudocysts. It's not a wart, although this area down here looks a little bit like an inverted follicular keratosis slash wart with squamous eddies, but that's not the best answer because you've always got a seborrheic keratosis up here. Squamous eddies mean benign. So whenever you see this, you should move away from squamous cell carcinoma. And notice in this field, even though there's some pseudoepithelial hyperplasia here, there's not a single mitotic figure. There's zero atypia here. So this is not a cancer in this case. And clearly it's not prurigo nodularis. So hopefully everybody got this right. It's pretty straightforward. And again, sometimes the board examination will give you some easy things. Not everything is going to be tough. Now, this one might be a little harder for you. You might have had to kind of look at this and scratch your head a little bit, but this is a very good case of this lesion, and this could very easily be on the exam. So this is fair game. They could show you this. They showed me, and I remember when I took my exam many, many years ago, the first slide they had on our exam, we used to have glass slides, was a hybridoma. And so I said, this is going to be an interesting case. Well, the second slide was molluscum. I said, why are you wasting my time on molluscum? I spent hours and hours studying on this. You shouldn't even insult my intelligence by having molluscum contagiosum. They did have a CMV on the exam and some other things. So they have a mixture of pretty easy stuff and some stuff that's a little harder. So this would kind of fall into the little harder category. You have to be able to recognize what this is. And at low magnification, it's an incisional biopsy, large specimen once again. Even though it's pretty large, it's very symmetrical. Okay, it goes all the way to the fat, but it's symmetrical. Now, we don't have the whole thing. This is a pretty big lesion. We can't talk about circumscription here, but if we sort of say, well, let's pretend like this is most of it, let's look at the bottom, and it's pretty much, you can draw a kind of a circle around it. It doesn't have a jagged, irregular kind of appearance going way deeply into the subcutaneous fat. So it favors benign when you see this pattern. What kind of differentiation is it exhibiting? Is it epithelial or non-epithelial? At least at this power, it's maybe epithelium, but we're not sure. It might be squamous. We're not really positive at this point. It certainly doesn't look like a spindle cell neoplasm or anything like that. So let's go to higher magnification and see what we see. And you can see that these cells, as we get to even higher magnification, you've got this abundant cytoplasm with all these granules in it. It's got these little central sort of hyperchromatic nuclei. They're very monomorphous nuclei. There's no atypicality. There's no mitotic figures. There's no pleomorphism. You've got this granular cytoplasm. All these are granules in here. And they're kind of pinkish and sometimes kind of whitish, but they're little granules. So whenever you see lots of granules with these dark sort of pinpoint black nuclei like this, you should think about granular cell tumor. And what is a granular cell tumor? Well, it's one of the neurocristopathies. It's in the family of Schwannian differentiation. So it's really a neural neoplasm. And basically what happens is the myelin breakdown products, the lysosomes engulf these things and they kind of get chock full, and it forms this granular cell morphology to the cell. So these are abortive cells attempting to form Schwann cells. So they're abnormal Schwann cells is a way to think about it. So if they're Schwannian and neural, what kind of markers are going to use to stain these? Well, you can stain S100 protein, they're just light up like a Christmas tree. So they're positive with S100 protein. Because these are breakdown products of myelin, they also stain positively for PAS stains. So basically it's the PAS positive stain is positive here, and also an S100 protein stain. And these are commonly seen in, so this is a 42-year-old woman with a lesion on her arm, but this is an interesting lesion that commonly occurs on the tongue of African-American patients. So if you get a picture of a bump on somebody's tongue, they stick their tongue out, it looks like there's a bump there, and they show you maybe a histopathology picture that looks like this, well, you'll know immediately the answer is granular cell tumor. And years ago, we used to think this, even way before my time, back in the days with the Russian pathologist Abrikosov, they used to think this was a muscle tumor, and it used to be called granular cell myoblastoma because they thought these were muscle cells, myoblasts. Well, they're not. We now know that they're Schwannian in nature, and all the granules are due to lysosomes that have engulfed abnormal myelin products, and they get filled up and they form these granules. So what's the diagnosis? Your choices here? Xanthoma. Well, that's a legitimate thing to put down, and that would be a tough thing to distinguish. But notice these are granules, and it's not that fine foamy cytoplasm we saw earlier with that xanthoma. It's obviously not a squamous cell carcinoma. Now, that might be something that would pick up somebody that's asleep at the wheel, because it's not uncommon to get pseudoepitheliomatous hyperplasia overlying these lesions. And if you do a shave biopsy of that, I've seen the diagnosis of squamous cell carcinoma missed, overcalled, because you get that pseudoepitheliomatous hyperplasia. Nobody even samples the granular cells. So you got to get down into the tumor to appreciate that that's pseudoepitheliomatous hyperplasia sometimes. So it's not a squamous cell, even though you can sometimes get overlying epidermal hyperplasia. It's not a renal cell carcinoma. Those get a lot more vascularity. There's more atypicality. They're mitotic figures, and those have clear cells, not granular cells. And it's clearly not an atypical fibroxanthoma, although there is a variant of AFX that can have a granular cell morphology to it. So they probably wouldn't put that on the exam, but the classic AFX is a spindle cell tumor, really wouldn't simulate this. And even if it was a granular cell variant of that, it would have more atypicality and mitotic figures and not these very small uniform nuclei that we see here. So that's granular cell tumor. Just remember the etiology of that entity. Okay, number 46. See, it's kind of taken by, kind of probably a shave, and then they said, well, there's still some left in here. Let's go back and shave it again. And notice from what part of the body it comes from. It's a very thin epithelium here. The epidermis is very, very thin. It's kind of thrown into folds. We don't see any, we see a few hair follicles, and there's small little vellus follicles. So this actually might have come from the eyelid area. Eyelid, which is an important thing to look at. And as it's inflammatory neoplastic, well, clearly it's not inflammatory. It's a neoplastic process. You've got these dark basophilic cells here, and they are sitting mostly in the dermis. We don't really see a lot of epidermal involvement. And then we also see some pallor here as well. So pale cells, or some pale material, and then these basophilic cells here as well. We're getting higher magnification, and you can see that basically you've got a sea of this bluish gray material. And we've talked about this several times now in this lecture. Bluish gray, you think of mucin. If you get a sea of mucin and you get these cells that are floating freely within that mucinous lake, if you will, that is a mucinous carcinoma, period, the end. And there's two types of mucinous carcinomas. There's primary mucinous carcinoma that we call mucinous carcinoma of eccrine glands, which basically, as you see here, would maybe be the diagnosis, because these look like they theoretically could be little small eccrine glands right over here, for example. And then there's metastatic mucinous carcinoma from other parts of the body, like the breast, for example. GI tract lesions can be mucinous carcinomas on occasion. So the problem arises here when we have to deal with the differential diagnosis of possibly a metastatic mucinous carcinoma and a primary mucinous carcinoma of the eccrine gland unit. And generally, sometimes you have to do a workup. If you're not sure, you say, hey, I can't be 100% sure that this isn't a metastatic lesion. So we have to often work the patient up to see if they've got an underlying carcinoma. There are really no good stains that 100% enable you to tell the difference between the primary and the metastatic one. So therefore, the board examination is not going to ask you about that. It's sort of controversial in the pathology literature, but I have not found one single stain that tells me just looking at a slide that this is definitely primary versus definitely malignant. Now, if it comes in as a solitary lesion from somebody's eyelid in an older person, then I'm going to strongly favor a primary lesion. And this is what these lesions look like. So this is mucinous carcinoma, and this is thought to be of eccrine origin. Now, there's one variant of this lesion that's been recently described. I don't think we have an example of it in this 60 slides here, but there's one that you need to know about. It's called mucin-producing endocrine sweat gland carcinoma. And I personally think that that's a variant of this same entity. And we call it endocrine because it stains positively for neuroendocrine markers, neuron-specific enolase, INSM1, just like the Merkel cell carcinoma we talked about, or synaptophysin. Those markers will stain positively in this entity in some cases. Those tend to be a little bit more solid. They may or may not have as much mucin as this. So I think if this were going to be one of those mucin-producing endocrine sweat gland carcinomas, it would probably look more like this. But I think probably, and I'm a lumper rather than a splitter, I really think that these are probably on the same spectrum, the same basic entity. So while they're still split apart in literature, and maybe for the purpose of the board examination, they might be split apart, I want you to think about them as possibly being the same entity. Okay, so your choices here were digital mucus cysts. Well, nobody chose that. I mean, clearly there's a neoplasm here. It's not a cyst. It's not just focal cutaneous mucinosis either, which is basically analogous to digital mucus cysts. It's not a mucocele. Again, we saw that earlier, which is just basically a lot of mucin with normal ducts and some mucophages in there. It does not have this type of neoplastic process. And then somebody put interstitial granuloma annulare. Hopefully nobody in the world would choose that, but that does have mucin in the dermis. So that's probably why it was thrown in there, to kind of possibly confuse somebody thinking, well, there's mucin, therefore it might be GA. Okay. Now what do we have? Okay, we've got a shaved biopsy. We see a marked verrucous epithelial hyperplasia, and at low magnification, we see some inflammation in the dermis. And notice that it's kind of got somewhat of an exoenophytic architecture to it, but it's not really cup-shaped and with a true sort of deep cystic type morphology like you see with the keratoacanthoma. So this is primarily going to be pseudoepitheliomatous hyperplasia. And even at low magnification, I hope you're able to appreciate now that all of these cells are not going to be lymphocytes here. You see how it's a little less dark than lymphocytes? There are going to be some lymphs in here, but this isn't solid lymphocytic infiltrate. There are going to be some neutrophils in here for sure. And there's probably going to be some histiocytes. And so whenever we see neutrophils plus histiocytes, we refer to that as suppurative granulomatous inflammation. And whenever you see suppurative granulomatous inflammation plus pseudoepitheliomatous hyperplasia, like you see here, your first thought, your reflex arc needs to be, infectious disease. I'm thinking this may be an infection. And it's probably going to be something like a deep fungal infection, a systemic mycotic infection, maybe atypical mycobacterial infection, something like that. So this is the classic pattern of a infectious process. So you say, okay, if it's an infectious process, where am I going to look? Well, there's several places to look. If you have abscesses in the epithelium, that's a great place to look because that's where the infectious organisms often get transepidermally eliminated. And lo and behold, right in this little abscess, there are these copper pennies, medullary bodies, sclerotic bodies of chromoblastomycosis. They're actually not just here, they're all over the place. So anybody that's not visually impaired here should be able to diagnose this and get this right. So this is one that I would expect I would hope that you would get right. And this is the kind of thing they're going to put on here. If they're going to show chromoblasto or something like that, or histo or blasto or whatever, they're not going to show you one with one organism that you have to spend, an hour looking for. They know that you've got, 30 to 40 slides to look at. They're going to just, make it where you can recognize it pretty quickly. And they want to test your ability to recognize these organisms in tissue, recognize the pattern, and then make a definitive diagnosis. And maybe even ask a second order question. on this. So here they didn't. They just asked a primary question. They said 57-year-old man with a history of renal transplant, so he's immunocompromised, gets multiple nodules on his shins and forearms. The best diagnosis is chromoblastomycosis. And then they list other choices that hopefully you would never think about. Keratoacanthoma. Well, if you kind of ignored that, you might miss it in that way, but, never just, if you get this kind of pattern, always look for organisms. Squamous cell carcinoma. Well, again, same thing. That's the same situation. You wouldn't want to call this squamous cell. You want to make sure you can identify the organism. So look for the suppurative granulomous inflammation. Then that's a trigger that you're probably dealing with an infection and not a neoplasm. Halogenoderma. Well, you've got organisms here that can look like this. It doesn't usually give as much granulomatous inflammation, but it can give you the pseudoepithelial hyperplasia with neutrophils, but it doesn't give you, the histiocytes as much. And then sporotrichosis. Well, obviously this is a sporo. So shame on anybody that would choose sporotrichosis here. You get the infectious part right, but you don't identify the organism. So again, they might ask you some questions about some of the causative organisms, cladosporium, pseudoallocheria, Allocheria boydii, some of those organisms. Make sure you just know a little bit about those. They're not asking a lot about dematiaceous fungi these days, but if they do ask a question, if you know what causes this, basically you're just going to get a free question. So go ahead and at least know a little bit about that, and you'll be better off than perhaps somebody sitting next to you. Okay, let's take a look at this one. Take a look at this piece over here. So we got a shave biopsy. Once again, what part of the body are we from? And notice that it's got a markedly thick cornified layer with no hair follicles, none. There might be one possibly here, but there are very few. So we're going to either be on volar skin or we're going to be near volar skin. Okay, and that's helpful. These things are, we don't use these clues just at random. They're helpful in making the diagnosis. So, this disease doesn't occur in very commonly on the trunk or extremity. It almost always occurs on the hands, or rarely on the feet, almost always on the hands. So we got an inflammatory process, low power lymphocytes here. See how black these are compared to the neutrophils in the previous one in the histiocytes? So we see that these are lymphocytes at low magnification. There's markedly thickened cornified layer, and then there's this pallor of the epidermis, upper level pallor of the epidermis. Okay, once again, when we think of pale, we think of ballooning degeneration possibly. And here we've got verrucous epithelial hyperplasia. We've got some epidermal necrosis, and beneath that we still have some ballooning degeneration. So remember, ballooning is where the cells basically fill up with fluid. And here, notice these nuclei. These are normal nuclei. These are pycnotic nuclei. So they're infected, or there's something going on with them that causes them to kind of die, like they're dying up here. And if you look carefully inside the cytoplasm of some of these, are these little pink eosinophilic inclusions, like right there. Hard to recognize, but you can see those. And then it's forming this large eschar, kind of purulent, not really purulent, it's really more of an eschar with dead epidermis and some inflammatory cells and some serum at the surface of it. So what causes ballooning degeneration? We had a previous of the nutritional deficiency, so that'd be one thing that you might think about. But this has also got these pycnotic nuclei, and it's got all these changes up here. And all of these cells up here that are dead, they're dead because they have been infected by a virus. So just like herpes virus infected cells eventually die, well, these cells also die because these cells have also been infected by a virus. So we have an answer here. We have a 30-year-old man presents with a evaluation of a nodule in his hand. It says the viral infectious etiology of this is which of the following? We have pox virus, parapox virus, herpes virus, polyomavirus, and flavivirus. Well, the answer to this is ORF. And so the right answer here would be parapox virus. Now, they wouldn't or shouldn't put pox virus and parapox virus in the same question. So I wouldn't make this question if I were on the board examination. So if you chose pox virus here instead of parapox virus, well, you're right. That's not a very good question. I would have maybe thrown in another weird virus, like maybe polio virus or something. But, basically, this is a parapox virus infection. So this is not smallpox, but it's in the pox virus family. And so that's really a little bit too sophisticated. But it's clearly not polyomavirus, which can be seen with Merkel and trichodysplasia that we see with people that are in renal transplants. spinulosa. It's not herpes virus, obviously, because that's going to give you the multinucleated giant cells that are acantholytic, and this is a ballooning process on the hand. It's not a flavivirus. Those are things like some of the weird, like West Nile virus and some of those things. That's an RNA virus. It would never give you a skin lesion like this ever. So this is this is a pox virus or parapox virus, if you want to think that. Parapox is really the right answer, but it's not, they wouldn't choose those. But just recognize this is ballooning degeneration. Now, anytime you get ballooning, think virus. You should think, the possibility of nutritional deficiency also, but I really always want you to think ballooning equals virus most of the time. And, if you see like oral hairy leukoplakia that's caused by Epstein-Barr virus, that gives you ballooning degeneration. This gives you ballooning degeneration. Herpes virus gives you ballooning degeneration. So think, especially these DNA viruses, and these are DNA. I recommend spending a little time learning about that too. The difference between a DNA virus, which gives you skin lesions like human papillomavirus or like this, versus an RNA virus that tends to give you measles, morbilliform eruption. So that's an easy way to think about those. If you're going to get an eruption from an RNA virus, it's usually going to look like measles. If you get one from a DNA virus, it's going to look like a wart or something analogous to that. Okay, let's move on to the next one. And here we've got a upside down shave biopsy. And there are all these little holes in the epidermis here. So something's going on up there. Why are there holes in the epidermis? That's not normal. Absolutely not normal. So whenever you see things that look like they don't belong there, you say, well, is the epidermis falling apart? Is there possibly a neoplasm in there that's replacing the epidermis? Are there clear staining cells in the epidermis that look white at low magnification? This epidermis is not normal. It's markedly thickened. Okay, so this is too thick. Shouldn't look like this. And let's go to higher magnification. And there's a reason that there are holes in the epidermis, especially if you get to this power. You can see that there's these large cells that have abundant cytoplasm. And then you look here, it almost looks like there are glands in the epidermis. Now, boy, that's not normal, is it? In glandular epithelium inside your epidermis, something bad is going on here. And notice how atypical these cells are all the way through the epithelium here, but sparing just the basal cell layer. A little teensy tiny area in the basal cell layer tends to be spared in this condition, like right here. Okay, so this is actually an intraepidermal neoplasm, and it's an intraepidermal metastatic neoplasm in this case, most likely. So you have a choice here. 57-year-old woman with multiple erythematous papules on her chest, okay, chest, woman, 57. The best diagnosis here is going to be Paget's disease, in this case of the breast. And what's happening here is you got underlying intraductal breast carcinoma that is really spread all the way from the breast into the epidermis. And it's actually, in this case, it's got this glandular epithelium within the epidermis. That's actually relatively uncommon. Usually it kind of looks more kind of like this, where we just get all these cells that have large, abundant cytoplasm with a normal rim of normal remaining epithelium at the base throughout the epithelium. And these cells have, if you were to stain this for mucin, for example, will be positive here. There are some other stains that we can do. We'll talk about those in a second. But this is a classic pattern of mammary Paget's disease. Now, extramammary Paget's disease can look pretty much the same. And that can also sometimes give you a glandular morphology in the epidermis that's associated with an underlying GU or GI carcinoma that spreads to the skin in a regional localized area. This is obviously the breast Paget's disease here in this situation. And then there's extramammary Paget's disease that's not associated with an underlying carcinoma. That just occurs de novo. We think maybe the Toker cells of the skin give rise to that tumor. We're not 100% sure, but sometimes you just see this somewhere that's not associated with any underlying carcinoma at all. So if you get this on the breast, you always have to work it up for underlying breast cancer. They always have it. You'll find it. You just have to look for it. If it's in the GU area, you got to look hard to make sure that they don't have an underlying GU cancer or GI cancer in that area. If it's just like sitting on somebody's neck or something like that, it can be just isolated and rare, but we do see that on occasion. So other choices here. Squamous cell carcinoma in situ, well, no, you wouldn't get glandular epithelium in that, so you can rule that out here, although there is a form of Pagetoid Bowen's disease, that I think we saw earlier, melanoma in situ, that can also give you Pagetoid morphology, but it wouldn't look good here. So we're not even giving you any stains here, by the way. We're just giving you the morphology. Advanced AK, well, no, would never be that. Metastatic adenocarcinoma of the bladder, well, that's clearly wouldn't look like this if it occurred on the chest. Now, that wouldn't really be the world's best answer, fairest answer if this was in the groin area, because you could say, well, you know, it kind of is a metastasis in a way. It's spreading locally. So I don't think they would ask you that if it was in that location, but this wouldn't occur on the chest. And if metastatic bladder cancer spreading to the chest would be a nodular lesion in the dermis. It wouldn't look like this. If you wanted to stain this, you say, well, I'm not really 100% sure. It doesn't have any glandular epithelium in it this time. And then we just want to make sure it's not, Paget's disease versus, Pagetoid Bowen's disease versus melanoma in situ versus MF versus, sebaceous carcinoma, et cetera. You would want to stain it for specific markers. And cytokeratin 7, carcinoma embryonic antigen, stains for mucin would all highlight this lesion strongly in this case. If you're trying to stain melanoma, obviously SOC protein MART1, one of those stains would be valuable to use. Pagetoid Bowen's would stain diffusely positively with cytokeratin. So again, depending on which neoplasm gives you intraepidermal involvement, Pagetoid intraepidermal involvement, you use a different stain for that. So go back, review those, make sure you know which stain to use when you're facing a Pagetoid intraepidermal neoplasm. That's likely to be on the exam somewhere, sometime. So just be prepared for that. Okay, we're coming up on the home stretch. We've got, I think, 10 more slides. And let's take a look at this one. So we've got a shaved biopsy and low magnification. Once again, you see kind of this diffuse infiltrate of something in here with all these little holes in it. So again, those may be significant, they may not be. Could just be artifact, but whenever you see these little teensy tiny holes like this with a dark black kind of background with, not everything is black, they're not all lymphocytes, probably some plasma cells, some other cells in here also. But these little tiny holes are helpful in this diagnosis. We're going to look at those at higher magnification. Most of these are artifact over here, but I think some of them actually are going to be pathologic. Is sort of higher magnification, we begin to see that these little holes are histiocytes, and they contain something in the cytoplasm. They contain these little tiny dots at the rim of these histiocytes. So these are histiocytes primarily with lymphocytes and some plasma cells in it. And when you see that pattern, bubbles plus intracytoplasmic organisms, the best diagnosis in this situation is leishmaniasis. Leishmaniasis. And when you get the marquee sign, like you see here, marquee or like the little light bulbs that you see on the, the marquee of the movie theater. That's kind of what somebody gave that name to it. We kind of like the Ferris wheel sign because there's a Ferris wheel here in Dallas. That's the State Fair of Texas, where these little cars of that Ferris wheel. So, but anyway, these are the intracytoplasmic organisms of leishmania. Okay, so they're the amastigotes. They don't have no cilia yet. There's no flagella here. These are just the little, and mastigote refers to flagella. So when it's got a flagellum there, when they start floating around in your body and swimming around in your body, it's got the flagella. When they get in your skin like this, they basically go into this sort of resting stage. And these are all little amastigotes here. So this is cutaneous leishmaniasis. The most common form of leishmania that to give you this marquee sign is the New World form of leishmaniasis. So again, if this were somebody that was from Baghdad or something like that, and you saw this, usually those organisms tend to be more diffusely present in the cytoplasm. They don't give you these marquee signs. This would be more like Leishmania tropica, Leishmania mexicana, one of the Leishmania species that's in the New World. And we see this in the United States too, by the way. It's not only confined to Mexico and South and Central America now, it's actually in the United States, even as far north as Dallas. So 30-year-old woman from southeastern Texas, that's an endemic area, comes in with a nodule in her cheek. That's a good location, exposed area. The fly bites there. Ruptoxanthoma, we've already seen one of those. Clearly the answer to that is no. Leishmaniasis, the answer is yes. Rose-eyed Dorfman, well, if you thought these were the large histiocytes of rose-eyed Dorfman and you didn't recognize the intracytoplasmic organisms, you might make a mistake to that. Well, clearly it's not that. Reaction to polymethyl methacrylate, we see a lot of filler reactions. Those look like little BBs in the skin. You don't have those intracytoplasmic organisms. And histoplasmosis, okay, that's another intracytoplasmic parasitized organism. So you do need to know those. Histoplasma, this, penicillium infection, Donovaniasis. There's about 5 of those, rhinoscleroma. You need to know those, but none of those give you the marquee sign like this. Okay, so this is a classic pattern, and you should be able to get that diagnosis correct. Histoplasmosis does not ever give you this. It actually, if it fills the organisms and you get a tiny capsule around those, they look a little different. These are little small, teensy tiny particles, if you will, inside the histiocytes, and they give you this beautiful little marquee sign inside the histiocytes. So bone up on those intrahistiocytic parasitized disorders. Make sure you be able to distinguish those from one another. You will be quizzed on that also. There's no doubt about that. Okay. I'll turn this over as well. And we've got a low power. We don't see a lot, do we? It looks pretty bland. We don't see very much of anything here. So is it inflammatory neoplastic? Well, who knows at this power? It might even be a pigmentary disorder. It looks like it's a little hyperpigmented at the base. That might just be the person's normal skin. But let's go to higher magnification, see if we see any inflammatory infiltrate or anything else at all here. And lo and behold, so go to higher magnification, we do see something here. We see these dendritic melanocytes that are present diffusely in the dermis here. So dendrites, make sure you can recognize these as dendritic melanocytes. There's a type of melanocytes, small, round, large, round, pagetoid balloon, oval, spindle, dendritic, and multinucleated. So these are the dendritic type here that you see. And basically, when you see just a sprinkling of dendritic melanocytes here, you should think about a variant of one of the blue nevus-like lesions, nevus of Oda, nevus of Ito, Mongolian spot. They all look the same. And here you got a choice. It says a 34-year-old woman comes in with a hyperpigmented patch on her left scapula. Okay, scapula. The best diagnosis is blue nevus. Okay, well, this is a type of blue nevus. Okay, but it's a patch. Is that the best diagnosis? No, because blue nevi are patches. Blue nevi generally tend to be small, round lesions in the skin. Nevus of Nanta. Anybody know what that is? That's a nevus with bone, with ossification in it, usually an intradermal nevus with coincidental ossification. Means little. Once again, if they put something weird on there, ignore it. It's not going to be the right answer. Nevus of Ito. That's the right answer. That's where those occur. Ito. Pat yourself on the shoulder if it's nevus of Ito. Nevus of Oda. That's on the face, right? The eye area, near the eye, often involves a sclera. So that's the wrong answer. Minocycline pigmentation. That doesn't give you dendritic melanocytes. That gives you fine granules that are kind of grayish black in the cytoplasm of histiocytes with some melanophages. So that wouldn't look like this at all. And if you're looking at a slide, and unfortunately you can't do this anymore because you don't have a microscope in there, everything is digitized. But we used to take our microscope and you could rack down the condenser and kind of focus up and down. And if it's refractile, you know it's crystalline, so you can tell the difference between melanin and say like hemosiderin or minocycline pigmentation, which is a crystal, as opposed to melanin, which is not a crystal. Melanin is a molecule. As you know, it's not a crystal. So basically, you can't do that anymore. But melanin is usually homogeneous. It's fine granules. You don't see these little large crystalline-like granules. So this is not any kind of drug or any kind of iron-containing product. So this is nevus of Ito. Ito. So the question there is asking you to distinguish, recognize it's a variant of blue nevus, and then know the anatomic location of that entity. Okay, so let's look at the middle one here. We've got a shave biopsy once again. And, you know, if you're going to get inflammatory skin disease on the board, they're probably not going to be shaves. They're probably going to be punches or excisions. So again, we're doing a teaching session. You know, we're using stuff that gets sent to us by, referring physicians in a board examination setting. They're the best cases in the world. So if you're sitting on the board, you have to come up with these slides. They expect you to get classic cases. You have to sift through lots and lots of your own material to find good examples. So here's a shave biopsy. Okay, and it looks pretty much like it's not neoplastic. It's got a lot of inflammation in the dermis. It kind of reminds us a little bit of the case of chromoblastomycosis we had a minute ago. It's got epithelial hyperplasia. It's got purulent crust. It's got an infiltrating the dermis that's not purely lymphocytic. So there are probably going to be some lymphocytes, maybe some histiocytes, maybe some neutrophils here. And we don't have the same kind of epithelial hyperplasia we had with the chromo, but we've certainly got a little bit of epidermal hyperplasia here. So let's go to higher magnification. And once again, we see suppurative granulomatous inflammatory reaction. So always look, hopefully you're able to see even right here, there's something going on here. Look inside the abscesses, look inside the histiocytes. And inside this histiocyte, right here, it's a good example. So if you're doing a bug hunt, that's where you want to look. Look inside the abscesses, look in the epidermis if there's transepidermal elimination of the organisms, look inside the histiocytes. And this one's got a spherule in it, a spherule. So what's the diagnosis that gives you spherules in the skin? Well, by far the most common one that you have to worry about is cocci. And here's another one. So once again, on a board examination situation, they're not going to make you search for the organisms. They're just going to make sure that you can recognize the pattern and then you know where to look and you can identify the organism when you see it. So this is coccidioidomycosis. These are spherules. This is as high as I can get on this magnification, but this is an intracytoplasmic spherule of cocci, and that's about the size of it. It's about the size of about 4 of these nuclei. It doesn't get giant like you see with rhinospordiosis, and those things are gargantuan. I bet if we look up here in one of the abscessed areas, we're probably going to see some up here. I don't see one there, but if we scroll around here, we're probably going to find some in other locations. So those are the best places to look. We don't have to, here's one up here that's been transepidermally eliminated. Good place to look. So I'm teaching you how to ace this exam. Always look inside the histiocytes, look inside the abscessed areas, and then also look up in the epidermis if it gets transepidermally eliminated. There might be a part of one right there. I'm not sure. So anyway, your choices here. And again, the nice thing, the reason they like to show these infections on the exam is because you can't argue with it. You can't go in and get some smart guy that says, wait a minute, I don't believe the answer. It has to be something else. Well, no, this is pathognomonic of cocci. So I'm going to show you something that is pathognomonic. And it's not crypto. And this was a 60-year-old man from Arizona, okay, endemic area. Multiple crusted nodules in his back, face, neck, and arms. They could have said for a 60-year-old a diabetic man, because these people often, are immunocompromised for one reason or another. And they are from the Sonoran Life Zone area, from Arizona, Mexico. We see some of it in Texas and West Texas. So your best diagnosis here is obviously cocci. It's not crypto. Remember what crypto looks like. You get the little organism with a big, huge capsule around it. Mucicarmine positive. If you do the GMS, it stains the organism, you get the capsule. The India ink, you get the capsule. You can see that. So remember what crypto looks like. Blasto, broad-based budding yeasts, not spherules. Paracocci looks like the mariner's wheel. We don't have that here. Sporo, hard to see organisms, sporo, but if you do, they look like little cigars. So this is classic for cocci. So no problem, right? Okay. All right. Excisional biopsy. Inflammatory neoplastic, clearly neoplastic. What kind of differentiation? It's dark, melanocytic. So, is this epithelial or non-epithelial? Well, you can argue that. So people think, melanocytes may be epithelial cells, if you will, neural crest, but it's melanocytic. The melanocytic category right away. Benign or malignant. Okay, let's draw a line down the middle of it. It looks pretty symmetrical, pretty well circumscribed here. We've pretty much excised the whole thing. So it's maybe about a half a centimeter or so in size, and here's the other half of it, which looks pretty similar. So it's relatively small, symmetrical, well circumscribed, vertically oriented, which favors benign. So we're going to favor benign here. So if it's benign, it's probably some type of nevus, not melanoma. And we may go to higher magnification to see tons of atypical cells, and mitotic figures may change our mind. But we go to higher magnification and there's no atypicality. There are all these dendritic melanocytes here with a spindly kind of sclerotic stroma. And we look down the bottom, cells are really heavily pigmented, and it goes really deep all the way down to the subcutaneous fat. Okay, and then down here, you've got some of these dendritic and spindle-shaped melanocytes. You've got some smaller round melanocytes that are heavily pigmented that kind of look like the cells that you see in a blue nevus, but also that you can see in the junctional component of a dysplastic nevus. So, story here: 45-year-old woman from Florida. We don't really care that she's from Florida, but she comes in with a pigmented lesion on her neck. Best diagnosis is primary melanoma. Well, we don't think it's melanoma, right? We don't see any mitotic figures. We don't have any pachytoid spread in the epidermis. We don't have any atypical cells. So we don't favor melanoma here. We favor benign. So we're going to throw that one out. It doesn't have criteria for melanoma. Recurrent dermal spitzes nevus. Is there a scar? No. Do spitzes nevi generally tend to give you this heavy pigmentation? Rare. There's some forms that can, but most of them don't. And they don't generally penetrate this deep down into the subcutaneous fat. Cellular blue nevus. Well, it's not really totally a cellular blue nevus. It's got the spindle cell component, and usually cellular blue nevi don't really have that component. They have more of the cells that are round and heavily pigmented, but they're not usually spindle and dendritic to the same degree as here. So that's not the best answer. Deep penetrating nevus is the right answer. And that's a subtype of blue nevus. So, if they probably wouldn't put a cellular blue and a deep penetrating in the same question, most likely. But anyway, that would be a better answer than just a plain old garden variety generic blue nevus. So again, sometimes both answers theoretically could be correct, but one's better than the other. So choose the better one. Don't choose the worst of the two. You want to choose the better answer. And then finally, metastatic melanoma. Well, it's clearly not that either. Okay, that would be a round papule in the skin. So that's absolutely not metastatic melanoma. So that's a deep penetrating nevus. And these classically will kind of have this deep tongue of heavily pigmented melanocytes that go all the way down into the subcutaneous fat. That's why they're called deep penetrating nevi. It's really a subtype of blue nevus, is really what it is. Okay, this one we've got a lesion that we get a second order question on. So we get a shave biopsy, neoplastic process, epithelial differentiation. It's contiguous with the epidermis. That's important in this case. What kind of epithelial differentiation is exhibiting? So it's got magnification, and we see the little fine snouts of apocrine differentiation here. Apocrine with some lymphocytes and plasma cells in the center of the lesion. We see that it's contiguous with the epidermis. We see that it's oozing and crusty over here a little bit. And here's another area where it's contiguous with the epidermis. What part of the body? Hard to tell, but this actually was probably from the face. The scalp is the most common location for this. So hopefully by now you've already said, that's a classic syringocystadenoma papilliferum. I know that answer. No problem. Well, let's look at our question. So they expect you to know it, because they're asking a 65-year-old woman comes with an evaluation of a lesion of posterior scalp, which is not true. They're making it really hard on you here, okay? Maybe associated with nevus sebaceous. Well, hopefully you know that that's one of the most common adnexal neoplasms associated with nevus sebaceous. That and trichoblastoma. They're very, those are the two most common adnexal lesions that we see in nevus sebaceous. So yes, may be present at birth or developed during childhood. Well, yes, this is a birth defect. It's a hamartoma. So yes, it's going to develop near birth. May undergo malignant degeneration. Every adnexal neoplasm may undergo malignant degeneration. So that's one of the reasons we excise them. It's rare, but they can. So uncommon, but it can happen. May spontaneously ooze a serosanguinous fluid. Well, of course, you've got these apocrine cells, they're producing apocrine secretion. So guess where that's going to go? Right to the surface. You can actually see there's some crust up here. So it probably was oozing. And that's one of the things these patients complain about. This is an oozing, crusty, ugly thing. I want it off my skin. And the last one is maybe associated with chondroid syringoma. That's a tricky question. You say, well, it's an apocrine lesion. Chondroid syringoma is apocrine. Maybe these occur together. No, they generally do not occur together. So that is not I would say that's really not a very, if it's happened at all, it's just basically random and it's not really an association. So that's the right answer. It's not associated with chondroid syringoma. So this is a good question where they would expect you to get the answer right away. So this shows you the level of knowledge. They're going to expect you to kind of know how to diagnose this. Okay, let's move on to this case. Number 55, and we got another, I think this is probably the right orientation here. Yeah, okay, so we'll look at it like this. And we've got a shave biopsy once again. I wish that a lot of these guys would have sent us punches, but they shave. And low magnification, are these lymphocytes? No, they're too pale. Some are over here, but the majority are not. So when we see mostly pale cells in an inflammatory skin disease, you should instantly be thinking granulomatous inflammation. And then you should say, is it what are the 5 patterns of granulomatous inflammation in skin? Is it suppurative granulomatous, like you might see with an infection, for example? Is it a foreign body granuloma? Is it sarcoidal? Is it tuberculoid? Ask yourself, what pattern of granulomatous inflammation is it you're seeing here. And this looks pretty diffuse. So there may be some suppurative inflammation here as well as these histiocytes. Some crusting up here, some ulceration. These lesions will often ulcerate. And we're going to higher magnification to this very dense, diffuse infiltrate of all of these histiocytes here. And as we go to highest magnification, and this is about as good as it gets with this, if you look carefully in the cytoplasm here of these histiocytes, especially these right here, you can see it the best, there are intracellular organisms again. Here's an even better histiocyte right here. Look at that. These little organisms inside the cells with a little clear pallor around these, that's capsular material. Okay, now is it the capsular material of crypto? No, that's a large amount. The ratio between the capsule and the actual organism in crypto is probably about 2 to 3 to 1. There's a lot more capsule than there is organism in crypto, especially in the mucogelatinous form. In this disease, the capsule is just a teensy tiny little capsule that you can barely see with our highest magnification here. And notice that they're present diffusely in this histiocyte. In fact, they're all over the place here, but you can really see it well in this one right here. So what's the best diagnosis here? Well, here's one that they're asking a second order question on. So they're expecting you to recognize these organisms here. 25-year-old medical student from Washington University, St. Louis, presents for evaluation of multiple crusted lesions in his back and extremities. He was most likely exposed to the causative agent when golfing in Arizona. Well, what do you get in Arizona? We just talked about that. That's cocci. So no, this didn't cocci. Traveling to Dubai. Well, what's endemic over in Dubai? Leishmaniasis. We already saw one of those. This isn't that, right? You see no marquee sign, and even if this were the Middle Eastern form, the organisms don't look like this. There's no capsule around them like you see here. Eating street food in Bangkok. So what are they asking for there? Penicillium marneffii, endemic in Thailand. Okay, HIV positive patients get that condition. Swimming in a Texas lake in the summer. They're asking about acanthamoeba infection. Well, these are way, way too small for amoeba. Amoeba are pretty large. You also see erythrophagocytosis in some of those things. They're much bigger than you see here. So this is obviously not amoeba. So that leaves you the last one, spelunking in a cave in Missouri. So what organism is endemic in Missouri? Well, histoplasmosis is, and you get it from caves, from bats. So basically, that's one way you can get histo. There are other ways you can get it also, but a cave and inhaling something that's down in a cave, like bat guano or whatever, that could give you histoplasmosis. So basically, that's the answer here. This is histoplasmosis. They asked an interesting question that you could pretty much rule most of those out just by process of elimination. So even if you didn't recognize the organisms, you look at that and say, it's not cocci, it's not leishmaniasis, et cetera. So you can pathology work your way backwards and figure out that this has to be histoplasmosis. Nothing else really looks like that. And nothing else will really give you that pattern of the question. So this is a beautiful example of histo. It's loaded with organisms. And, here you can see there's so many organisms. Sometimes there's so many, you say, gosh, you don't even recognize that they're abnormal. I mean, everything here is an organism. This person was probably severely immunocompromised when they got this. So histo, you really need to kind of look inside the histiocytes primarily. This doesn't give you that abscess pattern. And so you need to look for histo, look inside the histiocytes. Okay. So let's move on to number 56, down our last 5 slides here. And we've got an excisional biopsy. So again, immediately when you see an excision, you start thinking of a neoplasm. And we've got a ball in the dermis. We got some kind of a little aggregation of neoplastic cells in the dermis. It seems to be fairly small, given this large excision. And so is it benign or malignant? Well, small favors benign, but it's a little bit asymmetrical. And if we look carefully, we see that it's maybe causing the epidermis to be tinted up as opposed to involving the epidermis and going down. It seems like something's come up here and pushed everything up. So that might mean that it doesn't belong here. Okay, let's go to higher magnification. So is it epithelial or non-epithelial? It looks like it's got some sort of epithelioid morphology, but there's clearly something going on here. These cells are pale. And as we go to highest magnification, we see these cells are arranged these little kind of small tubular aggregations here. And we'll look around and we're probably going to see some pretty significant blood vessels in here. Lots of large dilated ectatic blood vessels associated with this lesion. And then let's look at higher magnification. There's some variability in size and shape of the nuclei. If you kind of have a good imagination, you say, gosh, that kind of reminds me of something I saw back in medical school histology. It kind of looks maybe like a little nephron here. Clear cells, lots of blood vessels in it with these variability, these hyperchromatic nuclei. You may see some scattermitotic figures. So let's read our question and see if we can figure this thing out. Because you say, wow, this looks like it doesn't look like it lives in the skin. It's got almost a grin zone up here, sparing the papillary dermis. So this was a 45-year-old man who came with an ulcerated nodule in his forearm. The best diagnosis is pyogenic granuloma. Well, no, that doesn't give you these clear staining cells like this. It kind of look like they're forming little nephrons like you see right over here. Metastatic renal cell carcinoma, the answer is yes, that's what it is. Vessels plus these little clear staining cells that are forming these little small aggregations that are recapitulating the kidney. And then clear cell sarcoma, melanoma soft parts. Once again, this looks like a metastatic lesion. It's small. Clear cell melanoma soft parts is a giant lesion that's very deep and goes all the way down into the fascia sometimes. So that would never look like this, almost never. And it would also have melanin in it, so that doesn't fit. But it does have clear cells, so that's kind of a fooler. And once again, if it's something weird that you've never heard of, ignore it. So that's a rare entity that we hardly ever see. Here's some red cells, because we know these things tend to be vascular and bloody. Nodular Hydranoma, well, you might think that, but once again, you see the little nephron-like organisms and structures here, and then you usually don't get the small cuboidal cells that are basophilic admixed with the clear cells, and this is almost all clear cells here. And then lastly, balloon cell melanoma. Well, that doesn't usually give this pattern either. It usually gives you some epidermal involvement and pagetoid spread, which we see this is involving the dermis alone. So this is a metastatic renal cell carcinoma, and it's a good example of that. So they're probably not going to ask you too many metastatic lesions on the board, but if they do, this is probably one of the ones they'll ask. So they might ask you this, they might ask you metastatic breast cancer, possibly metastatic colon cancer, but they're not going to ask you anything weird or too terribly many things about that. Now, they might ask you something about other diseases associated with kidney cancer, like the Burghardt-Dubé. They might show you this patient might have which skin disease, for example, which skin syndrome might be associated with this. So they could possibly ask you a second order question on that. So it's a pretty good example of metastatic renal cell carcinoma, and hopefully you guys were able to recognize that. So we've kind of ended up our session today with some interesting mixture of neoplasms plus some inflammatory things. And we want to hit some of these infectious inflammatory things because the board likes to ask them. Once again, these are incontrovertible. No one can ever question an infection because it's proven. So here we got a punch biopsy. And notice how you got all this white stuff in here, low magnification. Well, what causes white in the skin? Lipid, mucin, and glycogen. That's about 90% of it right there. Then you get other clear staining cells that have other stuff in their cytoplasm that makes it look clear, like we said, balloon cells and renal cells, probably glycogen actually inside those cells there primarily. But there aren't too many things that actually are truly present in the skin and are not artifactual that give you clear low magnification. So here we're going to see what all this stuff is. So this is clearly abnormal. So is it a neoplasm or inflammatory? We're not 100% sure yet, but let's go to higher magnification. And whoa, we get down here, and what do we see? We see all of these little small organisms floating what looks like freely, again, like in a sea of mucin. So we had the previous example of the mucinous carcinoma of eccrine glands, where you have the neoplastic cells floating freely in mucin. Well, here you have organisms with tons of mucin, a mucogelatinous capsule that is surrounding these organisms. So hopefully should be very, very easy for you that you said, crypto, no problem. Easy to diagnose, not a problem at all. And so this is basically a 55-year-old HIV positive man, widespread cutaneous lesions. Best diagnosis is crypto. So we've already looked at histo. We've already looked at cocci. Blasto, broad-based budding yeast. Are these broad-based budding yeasts? I see no buds. So the answer is no, these are not. This is the massive mucogelatinous capsule that surrounds crypto, okay? And it's obviously not paracoccidioidomycosis. That didn't give you a capsule either. So this is a beautiful example of cryptococcosis. And you know, what they could ask is something like that, expect you to know this. This gentleman presented with multiple lesions, or which kind of clinical scenario is commonly associated with this entity? Widespread umbilicated papule simulating molluscum contagiosum. Yes, man, that's the right answer. And we see a lot of patients back in the HIV era that were walking around, everybody thought they had molluscum and they actually ended up having this. So if you have somebody with HIV infection that you think has got molluscum, but they've got some CNS manifestations going on, you should think about crypto and you take a biopsy of it. So just remember that when you're dealing with crypto in an HIV positive patient. Okay, take a look at this one. I think we'll look at the middle one of this. There's actually 3 pieces. So once again, you want to look at all 3 when you're looking at this with your computer. And this was a 60-year-old man who came with a nodule on his flank. Do we think this is epithelial or non? Do you think it's inflammatory neoplastic? Well, clearly it's neoplastic. And actually, I thought that was epidermis, but it's not. This whole thing actually just kind of shelled out. So once again, we're dealing with an enucleation biopsy. Enucleation, benign. Probably thought this was a cyst. So somebody probably took a little incision of it, said, let's see if this thing pops out like a cyst, and it popped out. And they submitted it to the lab, and guess what? It's an epithelial neoplasm that's comprised of these aggregations of these epithelial cells that are small, round, cuboidal with this ductal differentiation over here. And it's also got, in some areas, some abundant mucin that's even undergone this metaplasia into chondroid. Chondroid plus an epithelial neoplasm with ductal differentiation. So what's the correct diagnosis here? So-called chondroid syringoma. Chondroid syringoma, or also known as a cutaneous mixed tumor. And so again, the best answer here, we had adenoid cystic carcinoma, doesn't look anything like this. That basically gives you multiple small cribriform areas. It almost kind of looks like a adenoid cystic basal cell carcinoma, but it's got more atypicality and it's a more aggressive lesion than a basal cell carcinoma. It's not microcystic adnexal carcinoma. You know what that looks like, small ductal ducts that go all the way down to the base of the specimen and get into the nerves. It's not a myxoid fibrosarcoma. There's no spindle cell component of this, so clearly it's not that. And then it's not a cellular neurothekioma, which gives you epithelioid cells and doesn't give you any of these. The cellular neurothekioma doesn't really give you much mucin in there. The nerve sheath myxoma variant of neurothekioma gives you mucin, but that gives you these little whorled areas of spindle-shaped cells that are demonstrating neural differentiation. So this is really the only one of those choices, if you know anything about dermatopathology, that would make any sense to you. So hopefully you'll be able to figure this one out pretty quickly. But it's something you should be able to recognize too. It's pretty characteristic. You got the epithelial elements, the mucinous elements, the chondroid, metaplasia, chondroid differentiation. So really, just nothing else really does this, except for a pleomorphic adenoma mixed tumor of the salivary glands. You're not going to need to know that, but that's basically the mixed tumor of the skin occurring inside the mouth. It's just basically the same entity, just a different variant. Okay, our penultimate case here. Let's take a look over here, and we've got another shave biopsy, and we've got at low magnification some type of epithelioid cells here, but they're pale. So is it inflammatory or neoplastic? Well, it's kind of got a pattern that, again, suggests that it may be granulomatous at low magnification. Let's go to higher magnification. And notice there's no involvement in the epidermis here. There's no pseudoepitheliomatous hyperplasia. And you got the sheets of cells that, again, have a relatively pale cytoplasm admixed with some lymphocytes. And let's go to highest magnification. Once again, it looks like that there's some kind of foamy, bluish gray material in the cytoplasm of these cells. And notice that there's the classic Grenz zone, the frontier, what Grenz translates into, between the epidermis and the inflammatory process going on in the dermis. And if you look carefully inside a lot of these cells, there are these little wispy areas here. They almost look like the ghosts, if you will, of organisms. So again, we saw a histo. Well, here we're seeing a different type of organism. And you get these cells that have this foamy material, and they look like little globi within the cytoplasm, like you see here, globi, like a handful of cigars, if you will. The classic diagnosis there is going to be Hansen's disease. So hopefully you would recognize that. The question, 30-year-old man, multiple nodules on his face and distal extremities. Which stain is best for this? A GS stain. Well, they probably meant GMS stain, and Gamorrean methenamine silver stain, so that's a typo, but it's not a GS stain. So a silver stain for fungi. Well, no, that wouldn't be the right stain here. A Gram stain, which is stained bacteria, no, that wouldn't stain this. An acid fast fight stain, yes, that would be the right answer, because all of these foamy cells here are so foamy because they're Virchow cells, named after Professor Virchow, who recognized these cells as being cells associated with leprosy. So this is borderline, it's probably lepromatous, polar lepromatous leprosy, not borderline. It'd be polar lepromatous, multibacillary, millions and millions of organisms in a patient like this. PAS stain, well, no, that again is stain for fungi. And then finally, a Giemsa stain, that doesn't really stain Leishmania. It makes the Leishmania organisms a little bit more visible compared to the background cytoplasm of the cells they're in. I've never used a Giemsa stain for that diagnosis because you see the organisms with H&E, you don't really need it. So basically, you can use a Giemsa stain for that. That's the use of it for that purpose. So this would be Hansen's disease, and you'd want to use a fight stain or an acid fast stain of some sort. So hopefully you recognize that. I would recommend learning a little bit about the treatment of Hansen's disease. They're probably not going to ask you a lot about it, but you should know a little bit about the reactions associated with Hansen's disease, a little bit of erythema nodosum leprosum, reversal reactions, the current regimen for treating the thalidomide indications. So make sure you know just enough about Hansen's if they ask you questions that you're going to get it right. They're going to trip you up badly enough with some of the bizarre, esoteric, basic science questions. So you may as well get the dermpath questions right that they're going to ask. All right, let's end up with a winner here. Hopefully you all can recognize this as a neoplasm at low magnification. And is it epithelial or non-epithelial? Well, or is it melanocytic? You want to throw it into that category. Well, it's nested and it's pigmented. And so, yeah, it's going to be melanocytic. And is it benign or malignant? Well, let's draw a line down the middle of it. Does that look the same as over here? Absolutely not. It's got like these aggregations of these cells that have almost coalesced over here, and here you got nothing. Here you got some large cells up here that have coalesced. So it's not symmetrical at all. Is it well circumscribed? Well, it kind of goes over here, goes to the base, over here, so probably not very well circumscribed. This other piece, it's transected at the base, so no, it's not too well circumscribed. So low magnification, we favor malignant. So what's the diagnosis? Malignant melanoma. So we're going to favor melanoma, and we're going to say, well, can we talk ourselves out of it? Is there anything else that can do this other than malignant melanoma? So we're going to go down to higher magnification. Somehow we see something in here that it's not even melanocytic, and maybe this is exogenous pigment or something like that. Well, maybe, but no, we're going to higher magnification. These cells are strikingly atypical. They're pleomorphic. They're atypical. They vary in size and shape. They're going to increase nuclear cytoplasmic ratio. You've got asymmetry at high magnification with these different populations of cells. You've got some residual junctional involvement, but you don't have a ton of junctional involvement, which is interesting. And in this type of melanoma, you may not have as much junctional involvement. Do we have mitotic figures? Well, let's look around and see if we do. You don't have to have mitoses in melanoma. If you scroll around, you might find one or two here, but this doesn't have a high mitotic index in it. So it's still a melanoma, but it doesn't have a lot of mitotic figures. There's one right there. So it does have some mitoses, probably another one right over here. So this is an example of malignant melanoma. Now, what question can they possibly ask us about this that we don't already know? Let's see here. So they say it's a 60-year-old woman with a pigmented lesion on her posterior right thigh. Best diagnosis, Spitz's nevus. No, it's asymmetrical. It's got all the features of malignancy we talked about, so absolutely not. Cellular blue nevus, again, that's not going to give you this pattern either. Nodular melanoma, the answer is yes. And one of the interesting things about nodular melanoma, and over here you do have some epidermal involvement, is that Wally Clark years ago used to talk about radial and vertical growth phase, and talked about, well, melanoma will kind of grow in the epidermis in a radial fashion for many years, then finally it kind of develops the ability to grow down into the dermis. And when it does that, it's got a bad prognosis. And it's some people still believe that, other people are not so sure. I think with new genetic testing, we found that some melanomas have abnormal genetics when the melanoma is still in the epidermis and looks the same when it gets into the dermis. Others sometimes do change. So there's probably some truth in it, but it doesn't happen in every case. But the concept of nodular melanoma is that the radial growth phase is very small, short. So it doesn't spend a lot of time percolating through the epidermis. It kind of has a short radial growth phase and gets into the dermis quickly, and therefore has less involvement of the epidermis. So we still have some of that over here, but it's not as much as we'd see, like, say, in a melanoma in situ that then went into the dermis, or so-called lineal-malignant that involved the dermis. Superficial spreading melanoma. So that's a more sophisticated question. They're asking the differences between two different types of melanoma. And superficial spreading melanoma tends to have a lot of pagetoid spread with a lot of large pagetoid cells. Here we don't really have that. Here we got these more epithelioid, large round melanocytes and small round melanocytes. So that would not be the best subtype of melanoma, but they probably aren't going to ask you to differentiate between the types of melanoma. They're really more interested in that you recognize that this is a melanoma. And then last of all, deep penetrating nevus, which we saw before, and this clearly doesn't look like that. So hopefully this has been a good exercise for you. Again, this is not everything that you need to know about dermatopathology. And I think if you are getting a high score on this, you're getting, say, 80% of these, you're going to pass. So that's the good news. If you're not getting 80%, you need to go do a little more work. And once again, you want to make sure that you get this correct, because that you do pass this part, because you don't want to not pass the exam and have to take it again. That's the kind of worst possible outcome that you can have. And I know guys that they did great on the basic science and the multiple choice, and they didn't do well on the derm path part, and they had to go back and take the whole thing over again. So don't do that. Know this information and then know some of the other stuff. So thanks again to us. We do education all the time, but really do want to thank Kim Campbell and Dermatology Authority for helping us with this. And then I would like to give you a plug for our upcoming conference in Vail, Colorado. Now, most of you guys, third years, will have already taken your board exams, and you're going to be done, and this won't help you with your board exam. However, if you would like to come and learn about clinical dermatology and therapeutics and some stuff related to business, because we're going to have some business stuff in there too. So if you say, well, hey, I'm going to be opening a practice, and maybe I need to know a little bit about business, or I'm going to be joining a practice, maybe about a little how to negotiate contracts and things like that. Come to the conference. We talk about those things as well as talking about dermatology and dermatopathology. We even have a little bit of stuff on wellness and burnout and some things like that. So it's a great conference. It's a family-oriented conference. Bring your family, bring your kids. It's a beautiful time of the year. It looks like this when you're there, and it's a high of about 75 degrees, and there's no humidity. So if you're coming from Florida or Texas like I'm coming from, well, you want to come and enjoy this beautiful climate and learn a lot of stuff. And for second and first year residents who are listening to this, basically it's a good pre-review for you for your next couple of years of your training, and for your second years, are going to be starting to get ready for the boards next year. There's tons of information in here that will get you prepped for that board. I mean, and we have like some slides like this that you can review. So if you want to get a derm path sort of jolt, if you will, you can come to the conference and learn a lot about derm path on your own, looking at our teaching slides. You can look at our great cases that we talk about. You can listen to the great lectures from great faculty, and you'll be a leg up on your colleagues. So come join us. We have a very inexpensive rate for residents. So again, if you want to get in on this, send us an email. I think it's dermpath@education.com or something like that. You can Google us and find this and shoot us an email, and we'll get you registered. So it's also, if you can't make it, we actually will have we're going to record everything this year, so it's going to be virtual after the event, but it's more fun to be there in person. And we already have about 60 or 70 people registered, so join us. So that's it. Good luck. You will pass. I have all the confidence in you, and I know that if you know this material, you're not going to have any problem at all. Be confident, be mindful, don't panic. Take a deep breath when you get into the room, and just use your criteria. Be systematic. Don't just jump to conclusions, and work through these questions, and you'll do fine. So good luck to you. Good luck in your career, and I would love to see you at some point at one of our conferences. So I hope you've enjoyed the session, and good luck to you.